life is complex.
So is our mental health. It cannot be understood by diagnosis alone.
Our philosophy is treat the person, not the mental illness. Hello, everyone, and welcome to another episode of Humanizing Mental Health. I'm Trent Nickers.
And I'm Jeremy Alcorn.
And I'm Amy Alcorn.
Yeah, and today we have a very special guest with us. We have Shara Ruffin. Did I say your name right, Shara? Right. Excellent.
You did.
Perfect. So I'm curious if before we jump into today's topic, can you introduce yourself to our audience?
I definitely can. Hi, everybody. My name is Shara Ruffin. I am a clinical social worker. I've been practicing social work for about almost 20 years now. I am now a consultant and I have my own company called Journey to Licensure where I help my colleagues pass their board exams, provide professional development. I also worked with LinkedIn on their advisory board. I'm a top voice in social work on LinkedIn, so I get give a lot of education to the platform regarding what social workers do. So that's what I do in a nutshell. I'm also an author as well. So I'll pause there.
Okay, wow, you've got quite a broad repertoire, and given the fact that you talk a lot about what social workers do and how we operate, that can be a really challenging subject, can't it?
Quite.
Yeah.
Quite.
Yeah, I think one of the things that really distinguishes social work from some of the other fields is, and that we talk about a lot here, is about how we approach mental health and wellness. One thing that I noticed when I was reading your bio is that you or you're a bit of an expert on personality disorders. Is that right?
Yes, that's one of my 23 specializations when I was a therapist.
Okay.
Yes.
Fair enough. Yeah. So with that in mind, I'm curious if you were to give sort of your perspective about what the general public really needs to know about personality disorders, what do you think that would be?
The first one would be just educating people about one, mental health in general. When it comes to personality disorders, there's always a lot of stigma about it because there's so much depicted in the media about people that have personality disorders as being bad or dangerous. And really just educating others to foster a more informed perspective about what personality disorders are, what are the symptoms, challenges among different types of personality disorders, as well as helping those that have them and their families as well.
Yeah, one of the things that jumps out at me as you say this, in a previous time of my life, I was working full time for the Canadian Armed Forces, and when we would have our clinical team meetings, then we'd be talking about and consulting with each other, and then I would hear a doctor say, "Oh, this is access 2." In other words, we can't do anything about this. Of course, for the general population at that time, the diagnostic manual had different access number 2 as well, where personality disorders were. He's basically saying this is a personality disorder. There's nothing we can do about it. And what a terrible message. What a terrible way of understanding things.
I agree. I totally agree. When I worked in a psychiatric hospital, I often, except for one psychiatrist I worked with who's pretty good when it came to talking about access to um, and talking about the challenges behind that personality disorder, but he really did a good job with the social workers in terms of educating them. That's when I became interested to specialize, excuse me, to specialize in personality disorders because I would come across so many clients that would have borderline personality disorder, schizoid, in an outpatient hospital where I often got a mixed bag of different types of mental health challenges. I definitely hear a lot. It just kind of perpetuates again that negative stigma behind personality disorders that there's nothing that can be done because that's definitely not true. And for a professional to say that, not, let alone a medical professional, is concerning. Um, but it's again has to go back to educating people and normalizing what personality disorders are. And just like schizophrenia, I know we're talking about personality disorders, but whenever people talk about psychosis, is often depicted as horrible or scary. And I think the more you educate people about the disorders, the better they're able to understand them and the people that they are supported by.
For sure. And what would be some of the foundational things that you would want people to better understand about a personality disorder or about the broad range of personality disorders?
So the one thing I would say when it came to personality disorders, for me, I would say is just first openly talking about some of the myths connected to personality disorders. Again, the most common one that I would often face when I had to facilitate conversations with family or someone that was newly diagnosed. In my hospital was borderline. And some of the one of my clients, I'll never forget, they said soul
Mhm.
sucking
Mm.
disorder. And I'll never forget that because I didn't know what that meant until I actually um, understood the impact of how it really can have challenges in communicating with family members when it came to some of the suicidality. But that was one I always personally had a challenge with, and oftentimes had to get educated about. But I would say the first thing, again, I have to go back to the stigma. There's so much in the media about what was called multiple personality disorders, now called, DID.
Mhm.
That is one that I ran across a lot in my hospital, and oftentimes a lot of my clients' family members would either disown them or they didn't have any supports. It was pretty sad. But I think, again, my heart always goes to educating people about what they have and how they can still live a normal life despite having them. No different than having generalized anxiety disorder. I had three different disorders. So I always, if you ever look in any of my social media, I vividly talk about some of the things I went through having GAD, not getting treated for almost 20 years, having ADHD, not being treated for almost 20 years, having a learning disorder, not knowing I had them until much later on in
Mhm.
life, being a mental health provider.
Yeah.
So I'm a big advocate of teaching people, not only those that are diagnosed with it, but just really dealing with some of the misconceptions that often foster fear.
Mhm.
There's something that jumps out at me, something I remember at another point in time. I was working in the medical, the universal healthcare system with addiction and mental health here. And we were once again in a team consultation. And I mentioned something and I said, yeah, well, I think this looks like it's a cluster A personality disorder. And the supervisor, who is a psych nurse, really a bizarre thing, getting to your point about education. Sometimes I think in the field ourselves, we don't necessarily always have a good idea of what we're talking about, because they looked at me like cluster, and they said cluster A. I was like, well, yeah, there's three clusters. Cluster A is odd, cluster B is dramatic, and cluster C is fearful. And it was really weird because they'd only ever discussed cluster B, and as if that was the only cluster of personality disorders that existed. So
That's interesting for
yeah.
me because oftentimes cluster B was the only one that existed.
Mhm.
And a lot of my colleagues, mine, or even other disciplines that I talked to, no one ever talked about cluster A or C. And
Mhm.
I ran across them a lot. But it's again, it's just important to talk about some of those myths. Um,
Yeah.
Now, I know for me, at least, one of the other things I faced was just the judgment that would come with just speaking out in existence that you have something, um, and really wanting to promote more empathy and compassion from even providers on how to be able to empathize with being newly diagnosed or even just going through the course of progression of the disorder itself. Um,
Mhm.
yeah. there still needs to be a lot more education around it, personality disorders and just mental health in general.
Yeah, I can only imagine because I haven't gone through it, but I know sitting down with Jeremy, like he's talked about like literally opening up the DSM and like going through that with the various diagnoses. Like even I don't know, probably in your experience, I know that I've had it happen where clients will come in and they will say, "Oh, I have this diagnosis, that diagnosis," and it's like going through, and it's like, going through reading it to them and then saying, does this fit for you and what does this mean?
How does it manifest?
Yeah, how does it manifest? And what purpose does it serve in your life? Is it about helping to define who you are, or really is it a key for you to get services, especially like even for me, I work with a lot of people with developmental delays, and there's a couple of them that vehemently will say, I don't want to be seen as somebody with a developmental delay, because they know all of the stigma that's attached to that. And it's about how can we fit that into your narrative so that it's something that can be a key, that can be empowering for you.
Yeah, rather than deficit. For sure, because that's the whole picture, isn't it? We're talking deficits throughout mental health. When we say mental health, we're really talking about mental illness, which is not really where we want our conversation to go. We want to be able to go, how is it that we become well?
A strengths perspective.
Absolutely.
Yeah, I definitely hear that. I think for me, one of the things I always dispelled was, especially I know there are cultural aspects to this as well, right? In terms of how cultures look at mental health. I know for my culture specifically, you say mental illness and you're the crazy person. My mom, I love her to death, but she used to tell my son, "Mom's going to the crazy house to work." That's what she would say. And some of it that I had to talk to even my mother. Look, I'm very real as you can get. This is where some of the conversations I would have with my mom. Like, do not tell my son that. Let him know I'm going to go help people that just need help right now. And he was little back then. He's almost 10 this month now, but it was one of those things that even families, how even culturally, how you perceive mental health and what that means to you, whether you have a diagnosis or not. It's so important to normalize that we all go through changes throughout our life, and our capacity to cope is different, depending on what that is, and whether it's environmental, socially. um, there's just a lot of different factors, and I just want people to know on a podcast, um, that it's just so important to get to the core of asking that question, like you said, what does this diagnosis mean to you, and how can I help you navigate that as you progress forward? um, Whenever I've done it from that space, from a strength-based perspective, as what was mentioned, it lessens that wall that's there, or even the anxiety and fear that's there, to know that the power dynamic is leveled enough that that person can open up to trust you. And of course, that takes time to do. But I worked, to give you kind of a picture of my mixed bag. My youngest patient was 18. The oldest patient I had was 94 years old. I would have all of them in one room together, 40 of them in outpatient care, and then I would have to run to the other side of the hospital for to deal with more high risk acute care. I had subacute care patients, but I would have to run around the hospital for people that were either in strictly outpatient, or they were in trying to remember, acute care, because they were just coming out of the hospital. So quite a bit. I was there for about 10 years doing that type of work.
Yeah, and when you talk about this, and you talk about the numbers of people, especially the notion of stigma, it's like stigma seems to be addressed within some diagnosis where there's far less stigma, it's much more normalized. Personality disorders, I agree with you. I don't think that they have had that same level of like reducing stigma, especially the cluster B, the people that have either a borderline personality disorder or histrionic personality disorder. I think because it's so, what's the word I'm looking for? Pervasive. in their social interactions that it becomes very hard. Individuals don't want to be associated with that because they're like, those are the kind of people that nobody likes, I guess, is kind of where they're coming from. No one wants to be around a person that's horribly dramatic. I don't want to be that person.
Like a burden type of thing.
Yeah.
It makes me think of, again, too, like as we're talking about this, because you recommended me that book, I love you, don't, or what was it? I hate you, don't leave me. Yeah. And like where it talks about like, with personality disorders and specifically borderline, how really on one level that is an adaptation to the environment that the person's going through. So how can we look at that again, going back to that strengths perspective is, how did that person grow up? What genetics were they given? And how are they really utilizing that as a way to function? Especially if we look at that from a child, like, if you have, a mother or father or an attachment figure that you can't securely attach to, of course you're going to have to do that as a way to try and get your needs met.
I definitely agree with that. And thinking about, I also did DBT a lot, especially with in outpatient care. That was one I had no idea what DBT was until my old former boss was like, "You're about to go in there with a bunch of borderline. You need to go get trained and certified in DBT." And I said, "Huh?" And it was very interesting because I didn't realize why it was so effective in terms of treating. But I will tell you, starting out as a newly minted therapist, I had no idea in terms of the skill set that you needed to really help them in terms of the emotional regulation piece, especially with borderline. But really understanding the pathology, if I had to think about Margaret Mahler individuation separation, where sometimes that personality disorder is born from the lack of attachment, the trauma, and you know all of this, of course. But of course, I have my teacher hat on. But thinking about what that person didn't have and how can they learn to build trust, how can they learn to have healthy relationships, um, and having a more holistic approach to how they can manage their emotions through mindfulness meditation, besides medication, but really for the provider really understand the components of how that personality disorder was born, besides borderline, but really frame it in a way that it's I'm losing my train of thought. That it's the client is able to understand how they can build upon um, not only their diagnosis, but how they can use it as um, a way to navigate their life going forward. And it's a lifelong journey. It's something, I had one client where she said, "Hey, I have borderline. This will go away with just this one session." I said, "No, this is a lifelong journey. This is a lifelong journey." Um, uh, it, it's interesting when it comes to when you meet different clients that have different perspectives on what that disorder actually means for them. I used to either get fearful, scared, or in denial. Um,
Mhm.
one of the two.
Yeah.
Yeah, and I really I appreciate what you said that, oh, it will just go away, because I don't know how many times I've heard that with like anxiety, depression. Oh, it'll just, it'll go away. And it's like, no, it's mental health is not the absence of illness, it's the continuation of wellness. So how can we help you get back on your path to wellness?
Yeah, interesting. A couple things you mentioned that really jumped out at me. And I want to tag this because I think it's really important. I'll come back to it. But the notion of trauma, but also the idea of people coming in, how they relate to the diagnosis. I've been very worried as some people come in and I'm like, I think that this diagnosis is relevant, but I'm worried about how they're going to perceive it, and being able to frame it in a way of understanding that this is about a portion of who you are, this one little few words doesn't somehow define everything about you. I also worry about people that come in and they say, I have borderline personality disorder. How did you find that out? I got on the internet, and they very well may be right. But the trouble is they somehow think that this one title is just going to somehow describe their whole life. It's like, no, like you accept yourself, and this is part of who you are. But we don't want you to somehow go, oh, you know what? This is just how I am, and people just have to accept me just the way that I am, with all of this distress and all of this dramatics that I bring into the world. Actually, that would be harmful. No, you can heal. It is a lifetime process, but this doesn't somehow give you a lifetime sentence either.
And it is a two-way street too. Like in relationships, you need to try to work on yourself, but you also do need people who love you and care about you.
Yeah. And I really like what you said there, Jared, because sometimes I think if we go through and we explain these diagnoses to people and help to humanize it, we are really giving them the keys to get out of their own personal jail.
And Shara, I'm really curious, coming back to that notion of trauma. Can you speak to that and how it relates to personality disorders? So that our audience gets that deeper view of how these develop.
Can you guys hear me? Because I'm having trouble with my audio, and I've been trying to play around with it a little bit here. So some of the things that I guess I'm thinking out when it comes to trauma is in terms of personality development. And keep in mind, to let you guys know, I have not had my coffee this morning. I wish I did, but this is the one day I decided.
Regulation.
Yes, I was like, this is the one day that I decided not to do coffee, and I'm like, my ADD brain is like, I need it. So I'm trying to think through this. But I think they're closely related, right? So when I think of trauma, especially during childhood, I'm thinking about just the different types of trauma. We have childhood trauma, complex trauma, single incident trauma, which would be like natural disasters, things like that. But when it comes to trauma, when it comes to personality development, thinking about attachment issues, that trauma can disrupt the formation of secure attachments, which we talked about earlier with borderline personality disorder. I'm thinking about emotional dysregulation, which we already talked about, managing emotions, identity and self-concept. So early trauma can distort somebody's individual sense of self. And it can form a lot of maladaptive personality traits. Now, to put that in more layman's terms, because I kind of just felt like I talked a bunch of clinical jargon that most people on the podcast probably won't understand. You guys do. But I'm thinking about, when I think about maladaptive, I always think about if you do this one thing too much, it becomes not good for you. That's how I always explain it to my clients when it comes to different ego defense mechanisms that we use, that too much of something can be bad. So when it comes to borderline personality disorder, I'm thinking about childhood abuse, neglect, abandonment. That's a trauma link when it comes to borderline personality disorders. Some of the symptoms I'm thinking about is emotional instability, fear of abandonment, intense and unstable relationships, impulsivity, and self-harm. When I think about antisocial personality disorder, I'm thinking about the trauma link could be association again with child abuse, neglect, disregard for others when it comes to anti-personality disorder, impulsivity, irritability, lack of remorse. A trauma link for avoidant personality disorder. I feel like I'm going through them all. Early experiences of rejection, criticism, humiliation. Some of the symptoms we know could be social inhibition, feelings of inadequacy, hypersensitivity to negative evaluation. And each one has its own. Dependent personality disorder. Here's another one. Trauma that's linked to neglect, lack of nurturing, right? Excessive need for care, that fear of abandonment. Those are some of the trauma links that I think about when it comes to where the pathology, psychopathology of personality disorders are born from. So I know I talked a lot. I was trying to think through without thinking about caffeine. About to get me a shot of caffeine.
That's actually great. Yeah.
No, I think that that's a great overview cross section, or we could say thumbnail sketch. You know, and for those individuals that are listening, and I'm thinking about, if you were to think about some good resources for clients or people that are wondering, hey, do I know somebody or do I potentially have personality disorders and I want to learn more. I know that we talked about like Google is not a good thing, but I know that there
No,
there are
or
there are some
TikTok.
good websites out there. But what are some good ones that you would think where you would want to steer somebody for the general public?
For the general public, I try to as much as I can. I kind of twitch when you say Google. I'm just like, no, because it's like a going down a rabbit hole. It's like going to TikTok, right? And there's so many. We know how powerful TikTok is. I love TikTok. However, I've had so many clients, even my own providers, go to, or even some of the people I supervise, go to TikTok. I'm looking at this disorder. Why are you going there? Um, I first to be for the general public to be educated, you definitely want to find official resources such as the Mental Health Association. That's one place place I think of specifically. When it comes to wanting to learn about disorders, you always, or even not SAMHSA, I can't think of them all. Um, but there are a couple of places, depending on who you talk to, because I know for my clients that are more African American, they go to different entities such as Black Girls in Therapy, or they may go to a place, they may go to a community place in their area that they can seek care. One of the things I do want to mention, specifically when it comes to culture and stigma, people usually will go to entities that they're connected with. And since I know for me, I live in the inner city, I live in Philadelphia. I didn't mention where I am, but many of my clients, when I used to work at a community health center, they usually would go to the person that they feel connected to, or they would find a community resource within their community, and especially in the urban area. And in Philadelphia, you can hit them pretty closely. But not everybody has access to that. Rural areas. I don't know where you guys are. Um,
Yeah,
but are there certain places? Oh, go ahead. I'm sorry.
I was gonna say, yeah, we're kind of rural. We're in Alberta, Medicine, which I would say Medicine is considered rural. Would you say,
Yeah,
Jeremy?
yeah. Like we're in a small city. There's about 70,000 people here, and lots of small towns around. So,
What
in
state is that? I'm
Canada,
sorry. You're in
sorry,
Canada.
in Canada, yeah, we have a universal healthcare system, and it's
Oh,
attached to the
wow.
province. So, so people, when it comes to receiving service, there is a universal service. It's pretty crowded. So it,
Oversaturated.
yeah, it's hard to actually meet the demand. So the Trent and myself are in private practice. Half of my time is with the Canadian Armed Forces at a base that's about half an hour away. But
Oh,
the
wow.
individuals that seek care from us generally then have insurance. Now, one of the things that I think is, and we've mentioned this before, but I think very important, is that individuals that are seeking help from us, they don't need a diagnosis. They don't need a diagnosis for their insurance company to cover their care. They just say, "I need help," which is, I think is very helpful because we don't have to necessarily use a pathological model. Where I know that in some areas of the world, in order for the insurance to pay, then you need a diagnosis. So when we're looking at diagnosis, we're looking at it from a lens that is about informing us. So it's like this does not actually define the problem. It gives a description of what is happening for you within the context of your life, which of course is a very social work thing. Um, but yeah, that maybe gives some context around where we're coming from.
Oh, see, I didn't catch that part. See,
Hmm.
the Canada, I was like, man, yeah, you guys do have a different system than in the US.
Hmm.
Um,
Mm-hmm.
yeah, you guys use a universal system. I wish we had that. Well, I know there's pros and cons. I'm sure there are
Totally.
cons to the system you guys
Yeah.
have, but in the US, oof, when it came to the healthcare system, especially mental health, it is not that great.
Hmm.
Our resources, the people that actually need it, especially in rural communities, even though technology has enhanced and there's telemental health, it's depending on the technology, it's not always available to people that are in different social economic classes here.
Hmm.
So it's a lot of people I know still will seek help online. Of course, we know that there are different types of mental health apps. AI, that's a whole thing. We can't even touch into that now, but there's all
Hmm.
types of things popping up now, um, technology wise, but I still think it's important for someone to be seen.
Yeah.
We're in the
Mhm.
areas you guys already know that with AI and the technology being the way it is, they're looking for different ways of trying to not necessarily replace us, but they make us more efficient. But all in all, for family members, at least here, it's so important to seek education, even from the providers, that your loved ones are being cared for. That doesn't, at least for us in US, it doesn't violate HIPAA. I don't know what the Privacy Act is for
Yeah,
you guys.
for sure. Like it's actually slightly different. For
Mhm.
us, we have Freedom of Information Privacy Protection Act. The individuals, because we're practicing outside of the universal healthcare system. In the universal
Okay.
healthcare system, they have their own internal ability to communicate with each other. So for us, we would need consent to talk, even to admit that are seeing someone's family member.
Okay. Yeah, I mean, we do have that for us, it would be the
Mm,
HIPAA Act here.
mm,
Um, but if it's, I know when I worked in outpatient, a lot of family members who were not educated about the disorder, we could still get education from us, or we would provide them with workshops or
mhm,
webinars if their family member was connected to our facility. And every facility it works very differently. Every state, at least in the US, when it comes to mental health, and the healthcare laws are different here too. And it can be very complex depending on the area of the country that you're in.
mhm.
Um, but thanks for kind of clarifying that. I'm a former military wife, and I'm
Oh,
a
nice.
military brat. So there's that. When you mentioned you work with the Canadian Armed Forces, I was
Yeah,
like, oh, I remember that life.
yeah,
Um,
yeah, for sure. Inside that system, to give you a little bit of a window, I don't know what other nations do, but prior to deployment and after coming back, the military member has to see a social work officer, not only to screen them for their mental health, but their psychosocial wellness. So you take a look at what's happening within your life. They don't get to deploy without me talking to their spouse.
mm,
And finding out from the spouse's position about what's happening in their life. So there's, of course, all those kind of social worky things. I wanted to bring something back, something that really jumped out at me, and that I'm super curious about. If you mentioned that you had worked with people within the cluster A, like schizoid, schizotypal, and that's one of the ones that fascinates me the most, because actually I don't think we see as many of them. But I'm
Mhm.
curious about um, what you've experienced in working within that specific area. Um, in particular, the thing that I'm most interested in is, as you talked with these people, is there any kind of common thread in terms of history that
Mm.
you find that tends to be where that vulnerability maybe comes from in their development? That's a big question, maybe.
Well, that
But
is, I'm like, he's asking where this no coffee. I'm trying to think through it as that is a huge question. Because I've
well,
been
maybe
out of
maybe I'll break it
practice
down.
for about 6 years.
Yeah,
So I'm
let
like
me
thinking
let me break it
Rolodex
down a
of
little bit.
experience.
The first part is, I'm curious, is your experience the same? That is, you don't, in personality disorders, you didn't see nearly as frequently people with schizoid or schizotypal. Am I
I did
correct? Or
not. Yeah, but only seen in my time of being in the hospital. I've only seen three,
yeah,
two schizoids and one schizotypal. It was very rare.
yeah,
Um, and they didn't stay with me that long.
hmm,
They did not
yeah,
stay with me that long at all. They're very when it comes to especially schizoid. I had one person who really, really just did not. He would just stare at me. He was 20
Mhm.
years old. He wouldn't really talk at all. But the one thing he did love to do was draw.
Mm.
Interesting.
So yeah, I'll never forget it because I had to find some type of way. The art, because we had different disciplines work together on a multidisciplinary team. One of them was an art
Mhm.
therapist.
Mhm.
So oftentimes after seeing me for just their group psychotherapy, they would go to these different types of specialty groups.
Mm.
Mm.
And with the schizoid, he didn't really talk, but a lot of his communication was through his art. And
Mm.
that was a good way that I was able to even though I can't draw anything but stick figures, but he would actually, it wasn't, I worked with him for about 3 months. And basically all we did is we would draw together. And his way of communicating to me was through his art. And he was really good at it. Um, but it was also still, I still felt that there was a void from what I got from, I can't, of course, go into his history too much. But what I got from him mostly was that mostly with him, it was his mindset around just trying to not be fearful of opening up. His pathology was more so related to, from my understanding, had a lot of trauma that related to his parents.
Mm.
One had borderline, the other one had schizophrenia.
Mm. Mhm.
Um,
Yeah.
it was very interesting case. When he was diagnosed at 20, and most of his time had been spent in the house. He rarely ever went out. He was homeschooled from home, everything at home.
Mm.
His
Mhm.
aunt took care of him, but his
Mm.
parents were in mental health institutions most of their lives.
I see. Yeah, and one of the things that's fascinating is what you describe as someone that it doesn't have much connection,
Hmm.
and that's this one area that I would say. First of all, I've only seen a couple of people. Once again, for in the last 20 years, um, the thing that strikes me very interesting about this particular disorder is that the innate human connection they don't seem to care about. It doesn't matter to them.
Of course, they're indifferent to social interactions with
Yeah,
others. Yeah.
yeah, and not in an autism way.
Hmm.
That person in autism is there's a clear kind of difference there. But and I've actually seen someone who was in a lot of therapy for a long time, and nothing seemed to make much difference. I was reviewing back through the case notes and went, huh, some psychiatrist mentioned that there was some traits that are in cluster A. And until we came to that, and I spoke directly with the person about what it is, and they started to reflect on their life, and they're like, "Yeah, my parents actually required me to act a certain way because that's what is socially expected, but I actually never cared about it. It was never important to me. It just a relationship ends. Oh well, go to Las Vegas with people and then just leave and go off on his own." And finally it was like this statement. I think it comes back to what you're saying before about understanding yourself is important. Um, because if we expect a fish to climb a tree, it will forever feel like it's a failure.
You should definitely write an audiobook. I can listen to you all day long. You articulate space so well. But I had to think through some of the commonalities a little bit. Some of the things that you actually just mentioned, social detachment, the restrictive emotional expression, their interpersonal difficulties I'm thinking about as you were talking. And I don't know if you found this, but I feel like to some degree they overlap with schizophrenia
Yeah,
spectrum,
yeah,
Mm.
some of
totally.
the
Mhm.
symptoms and their
Mhm.
genetic links.
Yeah. Hmm.
I found that to be very interesting,
Hmm.
but it was also very challenging. Have you seen a schiz? Have you talked to a schizo? Have you seen schizotypal? That is interesting.
I don't think I have. Mm.
Oh my God. Yeah. I saw one schizotypal personality disorder, and he didn't stay with me very long at all. However, it was very interesting in terms of his odd beliefs in magical thinking. He
Yeah.
wanted relationships, but he just couldn't sustain them. I mean, his mannerisms were so very much odd. Um, um, but he wanted a connection. So a lot of what we would do is working on some of his behavioral eccentrics, I
Mm-hmm.
called them.
Mm.
Some of them I definitely can't say on this podcast.
Yeah.
I could probably tell you after, but uh, it was always very interesting to work with him just because he wanted that connection, but just didn't have
Mm.
he didn't have the emotional. I don't want to say the emotional intelligence. More so, he didn't have the tools, and he
Mm.
didn't understand social cues very well.
Mm-hmm.
So, but they're very fascinating. You make me miss being a therapist.
Yeah.
Disagree. Maybe I'll
Mhm.
dabble here and there. I'm not sure.
And while we're this podcast is listened to all over the world, so while we've got you, we want to do a shameless plug.
Oh, shameless.
Yeah, that is. Can you talk about where people can connect with you and the um what it is that you're doing in your practice now for the people that would be interested in connecting with you?
Sure. And I'm not sure how much you guys in Canada have to deal with licensing, but
Hmm.
here we do. I think you
Yeah.
guys do
Yeah. Mhm.
have to deal with the ASWB. But yeah, so my shameless plug, I don't do them a lot,
Mm.
is I am a former social worker of, well, former clinical social work therapist of 20 years. I am still licensed, been licensed clinically for about 4 years, but been in the field for 20. I have 23 specializations. I am a LinkedIn advisor. I also, people can find me on all platforms. I have 7 different platforms, of course, Twitter, TikTok, LinkedIn. I have a podcast as well called Journey to Licensure. It's about to hit 200
Mm.
episodes. It's been a year and a half.
Awesome.
Um, it has different stories of people that I've helped who've passed their exams despite their disabilities, limitations, diagnoses, and these are providers, which makes it even more inspiring.
Hmm.
Strategies and tips. There are live scheduled study rooms that I do every week. Um, People, if they want to know more about me, feel free to just even put my name in Google. A lot of stuff will pop up there.
Hmm.
I'm someone that doesn't really, I don't really talk about what just uh, just blurring out a resume. I just kind of let people discover me wherever they find me, whatever platform they live on.
Hmm.
There's a lot I could say, but the one thing I will say is that I'm very passionate about my colleagues and helping them move on in their journey, whether it's their professional development or supervising them, which I do remotely, or helping them pass their board exams, which I've been doing for the last almost 4 years. And it's been quite a ride. So that's a little bit about me.
Hmm.
Yeah. I don't know if you mentioned this, but what's the name of your podcast?
Journey to licensure.
Journey to Licensure. Okay. Just wanted to make sure that we
Hmm.
got that in there.
Yeah.
Yeah. So, kind of as we're coming towards the end, kind of pulling things together, I always like to do a bit of a reflection on things that are going to stand out. And I guess I'll start. Um, First of all, it was really wonderful to be able to speak with another social worker, and someone that's been in the field for 20 years, and the things that you've done. You've had some, I think, experiences that hopefully our listeners learn a lot from in the inpatient care and all of the things you described. For me, the things that are going to jump out the most, I think, is destigmatizing the idea of personality disorders and remembering that those one-line descriptions don't somehow define our whole self. That we need to both accept it into our life, but uh, but also be able to recognize that we can evolve. We're not stagnant. Mhm.
Yeah, yeah. I really appreciate what you said there, Jerry. And think too, I agree with what you said in terms of like destigmatizing. And I think like where we had talked about like kind of at the beginning of the podcast, where sometimes these people try to like they're maybe not seen or maybe they don't want to come out and be able to represent themselves. I hope that this podcast helps people to maybe find that bravery to maybe seek more help, or to be able to, if they can, self-disclose in a way that empowers them.
Yeah, I found this podcast to be very informative and interesting. The part that I liked was learning about different types of trauma. I think often when I've heard about trauma, it's often we're talking about childhood trauma, but it was interesting to hear about the other types as well for myself.
And Shara, what about for you? What's going to be the big picture for you?
I think the big picture for me is to keep advocating for those that don't have a voice, or too scared to even speak it into existence. As someone that not only has been a professional, I've also had my share of struggles with mental health, and I've shared that across social media, because I was told when I was diagnosed, you don't look like what you've been through. This was a psychologist who told me. I didn't know if that was a comment or what, but it reinforced my purpose of sharing to help other people know that it's okay, that none of us are perfect, and that any of us can have a mental health crises, or even just a moment. Not just we're talking about diagnosis, I'm talking more just in general of, because it's one thing that if someone has a diagnosis, but what about those that just ignore their mental health at all? I did. So there's probably another podcast episode I could probably share that story on too.
Absolutely.
But I think it's just important for us to normalize disorders, normalize mental health in general. The more we talk about it, the more we can impact those that need help. And I hope from people hearing the podcast that they're able to gain a perspective and to be educated and informed, but also to normalize it in their own life.
Absolutely. I think that's a beautiful note to end on. And I just want to extend, I hope I'm not overstepping your chair, but you're more than welcome to come back for another podcast.
Absolutely.
All right. On that note, I'm Trent Nakers.
And I'm Jeremy Alcorn.
See you next time.
Thank you for joining us today. We hope that this message has been as meaningful to you as it has been to us. If you're looking for help, you can find us on Facebook at Humanizing Mental Health.